The chest X-ray shown below is suggestive of dextrocardia, pneumothorax, pneumomediastinum, pulmonary hematoma. So what will be the answer? Yeah, so this is suggestive of the dextrocardia. So you can see this, the cardiac border, it is completely on towards the right side. So which is suggestive that it is the individual is having the dextrocardia, and this is the apex, and this is the apex of the heart, right? Whereas you take the other options, in case of pneumothorax you will have hyperlucent lung fields, right, and the bronchovascular markings will be absent, right, and the trachea will be shifted to the opposite side. Okay, so that will be in case of pneumothorax. Whereas in case of the pneumomediastinum, in pneumomediastinum you have a pocket of air within the mediastinum. Still it is visible. Okay. Next, in case of the pulmonary hematoma, you will have the presence of mass within the lung shadow. So this is what will be the X-ray findings in other options, but in case of dextrocardia you will see that the apex of the heart is presently towards the right side, which is suggestive of your dextrocardia, right, and that we call it as situs inversus. Whereas situs solitus is what? It's a normal position, whereas situs inversus is that where the heart is present on the right side, right? Next question. Yeah, what is the incorrect about the image shown below? Shamroth window test seen in suppurative lung diseases, left to right shunts, loss of Lovey-Bond angle. Anyone? Yeah, so what exactly is this? This is like clubbing. So clubbing, it is present in case of cyanotic congenital heart diseases, right? So in cyanotic congenital heart diseases, the shunt will be from right to left. The shunt will be from right to left, it is not from the left to right shunts. Okay, now tell me, what are the cardiac causes for the presence of clubbing? One is cyanotic congenital heart diseases, you will have clubbing. Any other cardiac causes you will have clubbing? What are the other cardiac causes for clubbing? Very good, that is infective endocarditis. Okay, what are the respiratory causes for clubbing? What are the respiratory causes? Yeah, even, yes, very good Pranita, even atrial myxoma, good. Yeah, respiratory causes for clubbing will be interstitial lung diseases, also observed in cases of bronchiectasis, also observed in cases of the cystic fibrosis, also observed in case of the bronchogenic carcinoma, right, also observed in cases of the bronchogenic carcinoma, okay, and also observed in cases of the lung abscess, and also observed in patients with the empyema. So these are the other conditions, respiratory causes for the clubbing. Okay, tell me, what are the GIT endocrine causes for clubbing? Anyone? Endocrine causes for clubbing. Very good Dinesh. So that is thyroid acropathy, which is nothing but thyrotoxicosis. And what is another endocrine condition where you will have clubbing? The other endocrine condition where you will have clubbing is acromegaly. In acromegaly you will have the presence of clubbing. And what are the gastrointestinal causes for clubbing? Yes, so you will have that in case of the inflammatory bowel disease and as well as the primary biliary cirrhosis. Primary biliary cirrhosis. Okay, and what are the neurological causes for clubbing? What are the neurological causes? Very good Dinesh, that is observed in case of syringomyelia. So in syringomyelia you will have the presence of the clubbing. Okay, so these are the various etiologies for clubbing. And you take the other option, that is Shamroth windows test, right? So this is one of the popular tests for clubbing, right, where we need to keep right, so you need to keep both the nails together in the following fashion, and whatever that diamond shaped space which is present in between both the fingers, that will be absent in case of clubbing, and that is what is called Shamroth window test. Okay, so that will be there. and it is observed in suppurative lung diseases, that is lung abscess and as well as the empyema. Now, Lovibond angle, it is the angle between the nail bed and as well as nail plate, that is called Lovibond angle. There will be loss of Lovibond angle in patients with clubbing, right? So your 1 to 4 is correct, but your left to right shunts you don't have clubbing. It is in right to left shunts you will have the presence of clubbing, right? Now, the child shown below has with which heart disease? Endocardial cushion defect, partial anomalous pulmonary venous connection, PDA, tetralogy of Fallot, right? So what is this suggestive of? This is suggestive of Down syndrome. And in patients with Down syndrome, there are multiple congenital heart diseases. There are multiple congenital heart diseases in patients with the Down syndrome. Now, what are those multiple congenital heart diseases in patients with the Down syndrome? Okay, so these are all the congenital heart diseases in patients with Down syndrome. So Down syndrome, it is always a very special patient. What is this a very special patient? It is a mnemonic. A stands for atrioventricular septal defect. This is what is called endocardial Cushing defects, right? Endocardial Cushing defects. And V stands for VSD. S stands for the septal defect, that is ASD, that is ostium primum type of ASD is present in case of Down syndrome, and P stands for patent ductus arteriosus. So these are the congenital heart diseases which are present in patients with the Down syndrome, but out of all these, the most common will be atrioventricular septal defect. So what is the answer in this question? That is endocardial Cushing defect is another name which is given. The endocardial Cushing defect is another name which is given for the atrioventricular septal defect. So the answer is A. Otherwise, even your PDA is also the part of your the Down syndrome, but most common congenital heart diseases that will be observed in patients with the Down syndrome will be your endocardial Cushing defect. So that is the reason why the answer is 1. And how is that you are able to make out that the individual is having Downs? So the individual is having Downs by seeing that there is a saddle nose, right, and there is happy posing baby points to the Down syndrome. Okay, so these are the patients who have this endocardial Cushing defects, right? Next, moving on to the next. Yeah, S is septal defect. Yes, Ragul, S is septal defect. And what is that septal defect? Ostium primum type of ASD, and P stands for the PDA, that is patent ductus arteriosus. Okay, we'll move on to the next one, right? So a martial arts exponent complains of dizziness and syncopal attack. The ECG tracing is given below. What is the diagnosis? First degree AV block, Mobids 1, Mobids 2, and third degree AV block. I'll just zoom this ECG, please go through this. Yes, right, very good. So this is the ECG of the Mobids type 1 AV nodal block, which is nothing but Wenckebach's phenomena, right? Which is nothing but Wenckebach's phenomena, right? So in case of Wenckebach's, what is that you will notice? There is progressive prolongation of the PR interval, right? And at one point of time you have a P wave and there is no QRS complex. So this is what is called as the Mobids type 1, which is also called as the Wenckebach's phenomena. Whereas in case of the first degree AV block, what is that you will have? You will have only a prolonged PR interval. You will have only a prolonged PR interval. And Mobids type 2 already we have discussed, and third degree heart block also we have discussed, right? Now, can anyone quickly tell me what are the etiologies that will be causing Mobids type 1? Yes, can anyone quickly tell me what are the etiologies that will be causing Mobids type 1? Anyone? Telegram group link. Kujali, 1 minute. I'll just show you my Telegram channel link. 1 minute. Yeah, here in this patient, it is a martial arts where there is increased vagal tone. Increased vagal tone that can contribute to the development of Mobids 1. Yeah, very good, Bhava. So it is Mobids, the inferior wall MI, right? The inferior wall MI. Rheumatic fever, usually it will cause first degree AV block. Rheumatic fever, usually it will cause first degree AV block. Okay, very good, Vignesh. Drugs like beta blockers, right? Beta blockers, and then the calcium channel blockers, and then digoxin, Okay, then myocarditis. Yeah, so like the disease which is caused by Lyme disease, that is your Borrelia burgdorferi, that is Lyme disease. Okay, and then myocarditis. So these are the etiologies that will be causing Mobitz type 1 AV nodal block, right? Some of you were asking the Telegram channel, right? This is my Telegram channel link, that is Medicine Made Easy by Dr. Rajesh Gubba. So any doubts or anything that you can ask me on this Telegram channel, right? Okay, now we'll move back to right. Yes, a child adopt this knee chest position many times and has dusky discoloration of the tongue and extremities since birth, which is not indicated in management of this patient. So can anyone tell me, first of all, what is the diagnosis? Propranolol is not indicated, huh? Yeah, so diagnosis is tetralogy of Fallot. Diagnosis is tetralogy of Fallot, where you have VSD, subpulmonic stenosis, right ventricular hypertrophy, and as well as the overriding of aorta. So the drug which is not indicated in these patients, yeah, this particular patient is having a TET spell, which is nothing but a cyanotic spell. A cyanotic spell is present in this individual. So which of the following drug is not indicated? Morphine, which will decrease the preload; propranolol, which is a beta blocker; phenoxybenzamine; then the phenylephrine. And what is this phenylephrine? Phenylephrine is the one which will increase the afterload, that is your alpha 1 agonist, and phenoxybenzamine, it's an alpha blocker. So remember, the drug which is avoided during the TET spell will be the alpha blockers, that is phenoxybenzamine should be avoided, right? Phenoxybenzamine should be avoided. Okay, right. Moving on to the next question. Identify the abnormality in the ECG shown below in a lady suffering from the interstitial lung disease: P. pulmonale, PSVT, P. mitral, S1Q3T3 pattern. S1Q3T3 pattern. Anyone? Very good. So this is the ECG suggestive of the P. pulmonale, right? You can see that. So this is your P wave, which is tall, prominent P wave. How much will be the normal P wave duration or normal P wave amplitude? The normal P wave amplitude, it is less than 2.5 millimeters. But here if you see, the P wave amplitude is more than 2.5 mm, which is suggestive of the P. pulmonale. Which is suggestive of P. pulmonale. And in which condition you will have this P. pulmonale? P. pulmonale, you will have this in patients with right atrial hypertrophy. What all could be the causes for right atrial hypertrophy? Tricuspid stenosis can cause right atrial hypertrophy, pulmonary hypertension can cause right atrial hypertrophy, and even cor pulmonale can also cause right atrial hypertrophy. So now our patient is having the interstitial lung disease, which can cause the cor pulmonale, which can cause right atrial hypertrophy, which can cause the P. pulmonale. Now one quick question to all of you. Please tell me, okay, what are the causes for P. pulmonale? The causes for P. pulmonale will be tricuspid stenosis, pulmonary hypertension, pulmonary embolism, right? Then pulmonary stenosis, then cor pulmonale. Okay, one quick question to all of you. What are the causes for pseudo P. pulmonale? This is one of the PYQ. What are the causes for pseudo P. pulmonale? Anyone? Where do you have pseudo P. pulmonale? Any one of you quickly? Yes? Excellent. So pseudo P. pulmonale is observed in patients with the hypokalemia, right? So whereas in hyperkalemia, in severe form of hyperkalemia, what will happen to P waves? In hyperkalemia, what will happen to P waves? Very good, Dinesh. So there will be flat P waves or completely absent P waves is what you will observe in case of the hyperkalemia. All right, great. Yeah, and because your absent P wave is there, Sajid, the individual will have the ECG will have sinusoidal pattern, right, or which we call it a sine wave pattern. Okay. Now, so yes, a cyanotic baby has the following chest X-ray. The probable diagnosis is boot-shaped heart, box-shaped heart, snowman, normal heart. Yes, yeah. So you can see here. So what is this suggestive of? So this is suggestive of, right, this is suggestive of a boot shaped heart. And where do you have this boot shaped heart? That is tetralogy of Fallot. That is tetralogy of Fallot, and that too very clearly given here, cyanotic baby. So cyanosis is observed in tetralogy of Fallot, right? Now you take this box shaped heart. Where is that you will have box shaped heart? Where is that you will have box shaped heart? Very good. So box shaped heart is observed in the Epstein's anomaly. In Epstein's anomaly, you will have box shaped heart. I have that X-rays as well. I'll show you. And tell me, what are the scenarios where you will have snowman heart? Snowman heart. Right. So snowman heart, it is observed in case of the partial anomalous pulmonary venous connection or total anomalous pulmonary venous connection. You will have this snowman's heart. Okay, right. I'll show you that X-rays as well. That is Epstein's and as well as partial anomalous or total anomalous pulmonary venous connections. Right. Next. So and okay. So this is what is your now one quick point to this tetralogy of Fallot. What is being added? This will become pentology of Fallot. What is being added? That will become, yes. So if you add this ASD, that becomes the pentology of Fallot, right? Now in case of tetralogy of Fallot, because there is subpulmonic stenosis, the chest X-ray, if you see, pulmonary oligemia will be there. Why? That is due to decreased pulmonary arterial flow due to subpulmonic stenosis, right? And overriding of aorta, right-sided aortic arch, it is seen in almost 25% of patients. Okay, so this is about the chest X-ray in patients with the TOF. Now why did I place these images? In this image you can see that there is ST segment elevation, right? Now to call it as MI, what should be that minimum ST segment elevation in the limb leads, right? And what should be that minimum ST segment elevation in the chest leads to call it as MI? How much should be the ST segment elevation in the limb leads? Yeah, in limb leads it should be more than 1 mm. In two contiguous leads, yeah, in chest leads how much should be that ST segment elevation? Yes, so in chest leads it is more than 2 mm. In chest leads it should be more than 2 mm. That too in two contiguous leads, right? So that will be the ST segment elevation. And always the ST segment, you need to compare that with the TP segment. So the TP segment is what that will give you a comparison to the ST segment. All right. Okay, that was about the ECGs and chest X-ray. Now, which of the following conditions can be probable diagnosis for JVP recording mentioned below? Constrictive pericarditis, cardiac tamponade, cor pulmonale, then cor triatrium. In which condition you observe this abnormality? Very good. So the answer is constrictive pericarditis. What is that you are observing is, you are observing that there is presence of deep and exaggerated Y wave, and you are observing deep and the exaggerated X wave. Now which condition you will have deep and Y and deep X wave? That is observed in case of constrictive pericarditis. Now can anyone tell me what will be the differential diagnosis for this apart from the constrictive pericarditis? Very good, Atishaya. That will be restrictive cardiomyopathy. So in restrictive cardiomyopathy you will have deep X and as well as the deep Y wave, right? Now in case of cardiac tamponade, what will be the JVP findings? In cardiac tamponade, what will be the JVP findings? Very good. So you will have the absent Y wave, right? There will be absent Y wave, and you will have deep X wave, right? You will have deep X wave. So that is what you observe in case of the cardiac tamponade, right? Now in constrictive pericarditis and as well as the restrictive cardiomyopathy, you have the presence of the Kussmaul sign. What about in cardiac tamponade? In cardiac tamponade, Kussmaul sign is present or absent? Very good. So Kussmaul sign, it is absent in case of the cardiac tamponade, right? Now you take in case of cor pulmonale. Can anyone tell me what will be the abnormal JVP findings in cor pulmonale? abnormal JVP findings in cor pulmonale where the patient is having, let us just assume, only pulmonary hypertension. Patient is having only pulmonary hypertension. What will be the abnormal JVP findings? Absent A wave? No, absent A wave will be there in case of your atrial fibrillation, right? Very good. Bhava Dharini. Yeah. So it is tall or giant A wave. Right? Tall or giant A wave. Okay. Right. That is prominent A wave is what you will observe. Right. And where is that? Yeah. So cardiac tamponade, constrictive pericarditis, restrictive cardiomyopathy, everything I have given. Now tell me, where is that you will have regular Canon A wave? Answer, regular Canon A wave. Regular Canon A wave, not tricuspid stenosis. Right, very good. Bala Abhirami. So junctional rhythm. Right, junctional rhythm. Okay. So now tell me, where is that you will have the irregular, right, irregular Canon A wave. Irregular Canon A wave. Very good, excellent. So that is in complete heart block and as well as VT, ventricular tachycardia, you will have irregular Canon A wave. Done. Next. Now regarding the abnormalities of any other waves you want me to discuss? Okay, absent A wave already you people said, giant A wave you people said, Canon A wave you people said. Then X wave. Tell me, what is that condition where the X wave is absent or reversal of X wave? Tell me the conditions where, very good Kavin Raj, that is tricuspid regurgitation you will have absent of the X wave. And what are the conditions where you will have deep X wave? What are the conditions where you will have deep X wave? Three conditions are there where you will have deep or exaggerated X wave. What are those? Constrictive pericarditis, restrictive cardiomyopathy, and as well as the cardiac tamponade. So these are the three conditions where you will have deep or exaggerated X wave, right? And after X, your Y wave. So you tell me the conditions where the Y wave is completely absent, already you people said, that is cardiac tamponade. Tell me the conditions where you will have slow Y descent. Conditions where you have slow Y descent. Very good. So conditions where you have slow Y descent, that is in case of tricuspid stenosis. Tell me the conditions where you have early Y descent. Conditions where you have early Y descent. Early Y descent, yes, good. It is observed in case of tricuspid regurgitation, you will have early Y descent. Okay, chalo. Now, a hypertension patient is having severe chest pain, after which he developed unilateral ptosis and as well as the hemiparesis as well. Chest X-ray is shown below. What is the clinical diagnosis? The aortic dissection, acute myocardial infarction, cardiac rupture, AF with embolic stroke. Yeah, so this is the chest X-ray of the aortic dissection. So in case of the aortic dissection, what is that you are able to observe? You are able to observe that there is widened mediastinum. Widened mediastinum with a background history of severe form of chest pain is suggestive of the aortic dissection. It is suggestive of aortic dissection. Now, can anyone tell me why is this patient having unilateral ptosis? Why is this patient having unilateral ptosis? Stroke. Any other? Stroke, fine. Yeah, so there is like the individual is having development of Horner syndrome and development of the stroke. And because of the why is this? That is because of the dissection, you have the formation of the false lumen. This particular false lumen can be compressing the cervical sympathetic chain or can be compressing the vasculature supplying to the brain. Okay, so it is the false lumen compression causing the Horner syndrome and as well as the stroke as well in this patient. Okay, right. Now, what is the drug of choice in patients with the aortic dissection? Drug of choice. Very good, Aishwarya. So that is esmolol. All those who have said, right, esmolol. Esmolol is the drug of choice and alternative will be labetalol. Right, alternative will be the labetalol. Okay, right. And mainly type A dissections, they are very dangerous. they require immediate surgical intervention, all the type A dissections, because type A dissections are the one which will involve the ascending aorta and as well as the arch. Yeah. Association of the condition shown in the photograph include all except Turner syndrome, Down syndrome, ventricular septal defect, patent ductus arteriosus. So first of all, what exactly is this? It is the coarctation of aorta. And where exactly is this coarctation present? Yeah, it is distal to the left subclavian artery. Distal to the left subclavian artery. Yeah. So tell me, in which scenario you don't have this coarctation of aorta distal to the left subclavian artery? Right. You take in case of the Turner syndrome. What are all there in the Turners you see here? In Turners, you will have bicuspid aortic valve that will be causing aortic stenosis. Coarctation of aorta, it's a part of your Turner syndrome. Aortic arch anomalies are the part of the Turner syndrome, and pulmonary anomalous pulmonary venous connections and persistent left superior vena cava, they are the part of Turner syndrome. So Turner's question asked is except. So in Turner's you have the presence of the coarctation of aorta. Any other? Right. So that is your Down syndrome. Right. In case of Down syndrome, in case of Down syndrome, what did we discuss? A very special patient, that is atrioventricular Cushing defect or atrioventricular septal defect, and the other features that will be there in case of Downs will be VSD, PDA, and as well as tetralogy of Fallot. Right. So in case of Down syndrome, you don't have the association of the coarctation of aorta. Already just now I have given you this mnemonic, right? So a very special patient. These are the congenital heart diseases that you see in case of Down syndrome. That is atrioventricular septal defect, then VSD, septal defect, that is ostium primum type of ASD, then PDA, and you don't have this coarctation of aorta as a part of the Down syndrome. Right. So the answer is second option. Right. Abdomen must be compressed for how long for reflex to appear? 1 to 5 seconds, 5 to 10 seconds, 10 to 15 seconds, and then 1 to 2 minutes. Abdomen has to be compressed. Right. So this particular abdomen, it has to be compressed for nearly around 10 to 15 seconds in order to have this hepatojugular reflex. And in a normal individual, what will happen once you remove the pressure, the jugular venous pressure which is elevated will be only transient. That will rapidly return back to the baseline. Right, that will rapidly return back to the baseline. That we call it as the negative hepatojugular reflex. Whereas positive hepatojugular reflex is that the jugular venous pressure will be greater than 3 centimeters, and that will be greater than 15 seconds. That will be greater than 15 seconds. So that we call it as the positive hepatojugular reflex. Right, that we call it as the positive hepatojugular reflex. Now what are the conditions where you have positive hepatojugular reflex? Left ventricular failure causing right ventricular failure, then right heart failure, constrictive pericarditis, right ventricular infarction, and then the restrictive cardiomyopathy. So these are all the conditions where you will have the positive hepatojugular reflex, and in order to get that hepatojugular reflex, the right hypochondrium has to be compressed for nearly around 10 to 15 seconds. Okay, so the answer is 3 here. Right. Yes, severe stenosis of the valve shown in the photograph correlate with loud opening snap, loud S1, duration of mid-diastolic murmur, intensity of the mid-diastolic murmur. So first of all, what is being given to you here? Anyone wants the answer? Yeah, so the answer is yes. So this is the mitral stenosis, and in case of mitral stenosis, longer is the duration, severe is the mitral stenosis. Right, and shorter is the duration, right, less severe or mild mitral stenosis. Next is the A to OS gap. A to OS gap, if it is narrow, then it is suggestive of the severe MS. Right, if the A to OS gap is wide, then it is suggestive of the progressive MS or mild MS. Okay, so it is the duration of the mid-diastolic murmur. So severe stenosis of the valve shown in the photograph correlates with the duration of the mid-diastolic murmur. Right, and how much is the normal mitral valve area? When do you call mitral stenosis? Anyone? Normal mitral valve area. Yes, very good. So normal mitral valve area, it is 4 to 6 centimeters square. Right, and in case of the progressive mitral stenosis, what will be the valve area? Progressive mitral stenosis, what will be the valve area? So valve area will be less than 2. Great. So less than 2 centimeters square. And what is the most common cause for mitral stenosis? What will be the most common cause for mitral stenosis? Most common cause for mitral stenosis will be rheumatic heart disease. Okay, one quick question on mitral stenosis. What is the storage disorders that will be causing mitral stenosis? What will be the storage disorders that will be causing mitral stenosis? Very good. It is Hurler syndrome. It is Hurler syndrome. Okay, right. Now, what are the interventions that are being done in patients with mitral stenosis? What are the interventions that are being done in patients with mitral stenosis? Yeah, so one is your PBMV and the other one is mitral valve replacement. Now tell me, what are the contraindications for the PBMV? What are the contraindications for PBMV? Okay, I have that balloon in PBMV. Yeah, so PBMV we do that with the help of the Inno balloon. There I will discuss what exactly are the contraindications. Yeah, already you people said that is your calcification of the mitral valve. Then if the individual is having associated MR and if there is presence of left atrial thrombus, these three are the contraindications for the PBMV, and wherever the contraindications are there, you need to do mitral valve replacement. Okay, right. Now answer this. Diagnose the underlying medical disorder by ECG change in the photograph: hyponatremia, hyperkalemia, hypercalcemia, hypocalcemia. I'll just zoom this ECG. Yeah, anyone? Very good. So, right, so it is left atrial thrombus, because if you take the QT interval here, if you take the QT interval, so how much is the QT interval? You just calculate and just see. So 200, and how many small boxes it is occupying here? Almost 4 small boxes, so that is 160. So if you take the QT interval, that is nearly around 560 milliseconds is the QT interval. How much is the normal QT interval that we have discussed? In males, the QT interval will be 360 to 440 milliseconds. Whereas in females, the QT interval will be slightly for the longer duration, that is 360 to 460 milliseconds will be the QT interval in females, right? And here the QT interval is prolonged, right? Now, which electrolyte abnormalities you will have the QT interval being increased? QT interval is increased in patients with hypomagnesemia. QT interval is prolonged in patients with hypocalcemia. QT interval is prolonged in cases of the hypokalemia. So these are the conditions where your QT interval is being prolonged. So the answer is the hypocalcemia. The answer is hypocalcemia. Okay, and in hyponatremia you will not have the QT changes. Hyperkalemia you don't have the QT changes. Then hypercalcemia, can anyone tell me what will happen to the QT interval in hypercalcemia? Very good. So it will be short QT interval. It will be short QT interval. Okay, and if the QT interval is prolonged, what this will predispose to? If the QT interval is prolonged, what this will predispose to? Yes, this will predispose to Torsades de Pointes. And what is the drug of choice in patients with Torsades de Pointes? Very good, Dinesh. Drug of choice will be magnesium sulfate. Drug of choice will be magnesium sulfate. Tell me, what are the antiarrhythmic drugs which will be causing Torsades de Pointes? What are the antiarrhythmic drugs which can predispose to the development of Torsades de Pointes? Very good. So it is your class 1A antiarrhythmic drugs. That's all. Very good. So that will be, and the other one is class 3 antiarrhythmic drugs, that is your amiodarone. So your 1A and as well as, right, class 3 antiarrhythmic drugs. Chalo. Yes, these are all your pediatric x-rays, but let me just quickly recap here. Transposition of the great arteries. What is that you will have? You have this Egon string appearance. And this figure of 8 appearance, you see that in patients with the total anomalous pulmonary venous connection. So it is figure of 8 appearance or the snowman appearance. You will have this in case of total anomalous pulmonary venous connection. Then scimitar sign. Where do you have this scimitar sign? That is in case of the pulmonary anomalous, sorry, partial anomalous pulmonary venous connection. Partial anomalous pulmonary venous connection means where the pulmonary vein, instead of opening one pulmonary vein, instead of opening into the left atria, it opens into the inferior vena cava, right? It opens into the inferior vena cava, and there you can see this is what is called scimitar sign, where you have a sword like appearance over the right paratracheal area, right? Sword like appearance over the right paratracheal area. That is what is called as the scimitar sign, observed in case of partial anomalous pulmonary venous connection. And in case of coarctation of aorta, you have this classical figure of 3 appearance, right? In coarctation of aorta, you will have this classical figure of 3 appearance or reverse E sign, where you will notice that there is notching of the inferior rib in case of the coarctation of the aorta, right? And boot shaped heart, already just now I have shown you that is observed in tetralogy of Fallot. Then next is the box shaped heart, where there will be enlargement of the right atrium, or there will be atrialization of the right ventricle. That is what is called Epstein's anomaly, and here you will have a box shaped heart. Okay, now these patients, this is not Eisenmenger's, please strike this off. This is Epstein's anomaly, please make a correction of it, right? Epstein's anomaly. Now tell me, what can be the ECG changes that can be anticipated in these patients? ECG changes in patients with the Epstein's, they are at increased risk of right axis deviation. Okay, any other? These patients with Epstein's, they are at increased risk of, very good Monish, that is, they are at increased risk of development of WPW syndrome. They are at increased risk of development of WPW syndrome, which is nothing but a pre-excitation syndrome, which is nothing but the pre-excitation syndrome. Okay, so in case of WPW, what is that? You will have short PR interval, wide QRS complex, and as well as the delta wave. So Epstein's anomaly, these patients, they are at increased risk of development of your WPW syndrome, right? Next, and everyone I hope is aware of what is that particular drug associated with teratogenicity of Epstein's. What is that drug? Very good, that is your lithium. So lithium, it has the teratogenicity of development of the Epstein's anomaly, right? Now, so what exactly is this image? This image, it is suggestive of the angioedema which is observed when the patient is taking the ACE inhibitors. So with the ACE inhibitors, one of the adverse effect is development of the angioedema. Now quickly tell me, what are the contraindications for ACE inhibitors? What are the contraindications for ACE inhibitors? Contraindications for ACE inhibitors, right? So that includes bilateral renal artery stenosis, and the other one is pregnancy. So these two are the contraindications for the ACE inhibitors, right? And in case of bilateral renal artery stenosis, when ACE inhibitors are contraindicated, then what is the alternative drug that you will give? You need to give calcium channel blockers, right? And whenever you are giving ACE inhibitors in pregnancy, what will be the teratogenicity? What will be the teratogenicity? Yeah, even your renal failure and hyperkalemia. Good. What will be the is it stuck or you are not saying? What is the teratogenicity in pregnancy when you are taking, when the patient is taking ACE inhibitors? I think it's stuck. Yeah, so there will be development of renal agenesis, right? There will be renal agenesis. Okay, so this is about, yes. And the other what is the electrolyte that you need to monitor? That is potassium, because these ACE inhibitors are associated with hyperkalemia. Why? Because ACE inhibitors will inhibit the aldosterone synthesis, and that is the reason why you need to monitor for the potassium. And even if there is severe form of renal failure, you cannot give the ACE inhibitors because they will precipitate the hyperkalemia. Okay, right. Now tell me, what is the conditions where you will have this locomotor brachialis? Locomotor brachialis. Conditions where you will have locomotor brachialis. Okay, one is your aortic regurgitation. Next, apart from aortic regurgitation, yeah, so elderly individuals having atherosclerosis, right? Elderly individuals with atherosclerosis, you will have this locomotor brachialis. And the presence of locomotor brachialis in patients with the aortic regurgitation, that tells you that there is increased stroke volume or there is increased systolic blood pressure, and followed by that there is collapse, right? And followed by that there is collapse. Okay, so that is what is the presence of this locomotor brachialis tells you, right? Next, now you take the characteristic pulse. Yeah, tell me all the differential diagnosis for the Waterhammer pulse. All the differential diagnosis for Waterhammer pulse. Yeah, one is your AR. Next, tell me all the conditions. It is not just only the AR, multiple other conditions you will have this Waterhammer pulse. Very good, Sharon. So you will also have this in case of the MR. So you will have this in AR, you will have this in MR, and you will have this in all the hyperkinetic states. That is, what are all your hyperkinetic states? All these hyperkinetic states, it includes anemia, thyrotoxicosis, beriberi, AV fistula, then Paget's disease of bone. So all these conditions you can have this Waterhammer pulse. And this Waterhammer pulse, it is also observed in case of the PDA, patent ductus arteriosus. Also you can have the Waterhammer pulse. VSD, you can have the Waterhammer pulse, and even in pregnancy you can have this Waterhammer pulse. Okay, so these are all the other conditions where you can have the presence of the Waterhammer pulse. And what is another name for Waterhammer pulse? What is another name for Waterhammer pulse? Right, this is also called Corrigan's pulse, right? So you should not get confused between these two names, that is Corrigan's pulse and as well as Corrigan's sign. Yeah, please tell me, what is Corrigan's sign? Yes, what is Corrigan's sign? Anyone? What is Corrigan's sign? Very good. So Corrigan's sign, this will be your dancing carotids. So Corrigan's pulse is your Waterhammer pulse, whereas Corrigan's sign is the dancing carotids, right? So this is about the story related to the Waterhammer pulse. Next followed by that, yeah, and in case of the aortic regurgitation, what is that important sign that you will observe in the nails? In chronic AR, what is that important sign that you will observe in the nails? Yes, that is called Quincke's sign, where you have alternative pulsations within the nails. Alternative pulsations within the nails. Okay, right. Yes, now tell me, okay, I'll give you markings 1, 2, 3 and then 4. Yeah, please tell me where exactly is the point for the aortic valve closure. Yes, so yeah, it is exactly the incisura. Right, it is the incisura, that is a point where your aortic valve and as well as the pulmonary valve closes. Okay, and this P stands for the percussion wave, D stands for the dicrotic notch, right? So, and this particular incisura will tell you that the diastole is about to start, right? The incisura is the one which will tell you diastole is about to start. It is not D. D is your what? Dicrotic notch, where the after the closure of these semilunar valves, the pressure slightly increases and again it will return back to normal. Your point 3 suggests you have dicrotic notch, and it is your point 2. Okay, this is your incisura. That is the point where the semilunar valves will close. Right now, yeah, tell what is the definition of the pulsus paradoxus, and which conditions you will have pulsus paradoxus. Which conditions you will have pulsus paradoxus? Not left ventricular failure. Yeah, first of all, what is pulsus paradoxus? Normally right? Normally during inspiration, right? Normally during inspiration, the systolic blood pressure drops. And how much will be the drop? Less than 10 millimeters of mercury. But in pulsus paradoxus, the systolic blood pressure decreases by more than 10 millimeters of mercury. That is called pulsus paradoxus. Now tell me, what are the conditions where you will have pulsus paradoxus? That is in cardiac tamponade. What are the other cardiac conditions where you will have pulsus paradoxus? What are the other cardiac conditions where you will have pulsus paradoxus? Right. So yeah, occasionally you can also have this in patients with the constrictive pericarditis. What are the respiratory conditions where you will have pulsus paradoxus? Respiratory conditions observed in severe COPD, observed in status asthmaticus, right? Status asthmaticus. Okay. Then what are the other conditions? Apart from this, what are the other conditions? Very good. Massive pulmonary embolism. Next, any physiological condition where you can have this pulsus paradoxus? Very good. So that is pregnancy. Pregnancy, there can be pulsus paradoxus. Yeah. The other abnormalities in obesity, you can have this pulsus paradoxus, right? And you can also have this in hypovolemic shock. So these are all the conditions where you can have the presence of the pulsus paradoxus. Okay, right. Now coming to pulsus bisvariance. Pulsus bisvariance is what? You will have two peaks in systole, right? You have two peaks in systole. Yeah, tell me which conditions you will have this pulsus bisvariance. Very good. So you will have this in patients with HOCM. Hypertrophic obstructive cardiomyopathy is the scenario where you will have two peaks in systole. What are the other conditions? What are the other conditions? You should not tell AS only, Vijaya. AS should be associated with, yeah, so AS associated with AR. Then, or isolated severe AR, you can have this pulsus bisvariance. It is characterized by two peaks in the systole, right? Where is that you will have dicrotic pulse? One peak is in systole and the other peak is in diastole. The other peak is in diastole. Yeah, where is that you will have the presence of dicrotic pulse? Yes, dicrotic pulse is observed in cases of dilated cardiomyopathy. So in dilated cardiomyopathy, you will have this dicrotic pulse, right? Yes. Pulsus alternans. Very good, Pranita. So pulsus alternans, where you have this alternate, right, where you have alternate large and small waveforms, that is called pulsus alternans. And you will have this pulsus alternans in patients with severe left ventricular failure. In severe left ventricular failure, you will have this pulsus alternans, right? No, it is not ventricular premature contractures, not in ventricular premature contractures. Okay, toxic myocarditis, yes, even in toxic myocarditis, right, even in toxic myocarditis you will have this pulsus alternans, which is correct statement. Okay, right. Now whereas you take ventricular premature contractures, some of you are saying VPC, Pranita, so tell me, how is this your VPC different from pulsus alternans? How is your VPC? So that is what is your pulsus bigeminus. So pulsus bigeminus, you will have it in ventricular bigeminy. So how is it different is, in ventricular bigeminy, you will have a normal waveform, you will have a ventricular premature contracture, and then you have a compensatory pause, and again you will have a normal complex, then you will have a VPC, and again you have a compensatory pause. That is what you will observe in case of pulsus bigeminus or your ventricular premature contracture. Ventricular premature contractures are always associated with a compensatory pause, whereas in pulsus alternans there is no compensatory pause. That is the difference between your VPC and as well as the pulsus alternans. Okay, now tell me which conditions you will have electrical alternans in the ECG. Tell me which conditions you will have electrical alternans in the ECG. Very good. You will have that in cardiac tamponade. In cardiac tamponade, you will have this electrical alternans. Okay, right. Yes. Now this is how you need to examine the water hammer pulse. This is how you need to examine the water hammer pulse. So what is that you will notice in the water hammer pulse? You will notice that there is a rapid upstroke, and this rapid upstroke is observed during the systole, and this will be followed by rapid upstroke, and this will be followed by collapse, and this collapse is observed during the diastole, right? This collapse is observed during the diastole. Okay, so this is what is called as water hammer pulse. Now can anyone tell me why is it given the name the water hammer? Why is it given the name water hammer? What toy? What toy is that? Yes. So they have compared that with Victorian toy. Even in the Victorian toy, okay, so there was a rapid fall and rapid rise, right? So they have compared this with the Victorian toy, and the name of that Victorian toy is water hammer, and that is the reason why the name is given as the water hammer pulse. Okay, right. Now regarding the JVP, these are the normal waveforms. Normal waveforms. A wave is your atrial contracture. C wave is cusping, bulging of the cusp into the right atria during isovolumetric contraction. X wave is your ventricular relaxation. V wave is due to venous filling. Y wave is due to atrial emptying. Y wave is due to atrial emptying. So this is the normal JVP waveforms, right? But now you tell me A wave corresponds to which phase of the cardiac cycle? A wave corresponds to which phase of the cardiac cycle? Because they will ask you correlation between the JVP waves and the cardiac cycle, that you should be able to tell. A wave corresponds to which wave of the cardiac cycle? Right, that is late diastole, which is nothing but atrial systole. Late diastole, okay, which is nothing but second rapid filling. Second rapid filling. C wave corresponds to, very good, so this will correspond to isovolumetric contraction, which is nothing but the early systole, which will correspond to the early systole. Yeah, X wave corresponds to, right, X wave corresponds to the mid part of the systole, okay, and V wave corresponds to V wave. Yeah, after mid it will be late systole. Then finally Y wave corresponds to, anyone? Y wave, what does it corresponds to? Yeah, so this will corresponds to your atrial emptying, which is nothing but the early diastole, right, which is nothing but the first rapid filling. Okay, so that will be your Y wave. Chalo. So this is about correlating the JVP waves with the cardiac cycle. Right, now we will move on to the discussion of the cardiac murmurs. So in cardiac murmurs, the images are very, very important. So this is a image of the continuous murmur. Tell me physiological conditions where you will have these continuous murmurs. Physiological conditions where you will have this continuous murmurs. Very good. That is mammary souffle. You see that in case of pregnancy. Mammary souffle. Next. Any other physiological condition? Any other physiological condition where you have the continuous murmur? One, you people said pregnancy. Good. Pregnancy, lactation, same. Next. What are the other conditions? Anemia, no. Preterm, that all comes under pregnancy only, na? And anemia, is it a physiological condition, Mugilan? I'm asking physiological condition where you have the continuous murmur. Child, very good. Who is that? Sundaram, excellent Sundaram. That is the venous hum. That is venous hum. Where will you auscultate for the venous hum? Where will you auscultate for the venous hum? So you have to auscultate for the venous hum in the supraclavicular areas, right? In the supraclavicular areas, okay, right? Then you have many other pathological conditions where you'll have this venous hum, sorry, pathological conditions where you have this continuous murmur, that is the PDA. Now can anyone quickly answer me which intercostal space you will auscultate for the PDA murmur? Which intercostal space you will auscultate for the PDA murmur? Anyone? Very good. So the PDA not second intercostal space. Where is the PDA murmur auscultated? That is first. That too left first. So left first intercostal space. Vijay, what is this particular left first intercostal space called? What is this left first intercostal space called? Left first intercostal space is called, yeah, already this Bala, yeah, one student Bala Abhirami has already answered. Very good. This is called Gibson's area. This is called Gibson's area, and that we call it as the Gibson's murmur. Gibson's murmur. Okay, right. And you have many other conditions where you have continuous murmurs. AV fistula, coronary and peripheral AV fistula, then ruptured sinus of Valsalva, then all the stenotic lesions, renal artery stenosis, carotid artery occlusion, right, and celiac artery occlusion, then branched pulmonary stenosis, carotid occlusion, all these occlusions also you have this continuous murmurs. And what is the description of the continuous murmur? It starts from S1, overlaps S2, there can be even a peak at around S2, and it will progress up to the S1 again. So either it can be a part of diastole, right, or the complete murmur, I mean continuous murmur, it can be part of the complete diastole, but it should be overlapping S2. It should be overlapping S2. Okay, right. Yes. Now this is your pansystolic murmurs. Yeah, please tell me which conditions you will have these pansystolic murmurs. Right. You should not tell simple MR, Pranita. If you tell MR, I will tell it is early systolic murmur. What is that you should add to that MR? No. You people are not answering correctly. No, MR, VSD, no. Yes, very good, Vignesh. So it should be chronic MR. It should be chronic MR. Next. That's all. Only chronic MR. If you tell me VSD, I am not happy. I am not happy with VSD. Very good, Pranita. Excellent. So that is large VSD. And then chronic TR. Chronic TR. And where will you listen this chronic MR murmur? That will be at the apex. And where it will be radiating to? It will be radiating to axilla. When it will increase on expiration. Right? Chronic MR will increase on expiration. Whereas large VSD. So large VSD, you will listen this in the fifth left intercostal space, parasternal line. And it will not change with respiration. It will not change with respiration. Whereas chronic TR murmur, you will listen this in fourth left intercostal space, parasternal line, and it will increase on inspiration. So what is that? All the right sided murmurs increasing on inspiration. What is that particular sign? What is the name of the sign when all the right sided murmurs are increasing on inspiration? Not Gallaverdin, man, not Gallaverdin. Gallaverdin is an aortic stenosis where the murmur will be radiating to the apex. All the right sided murmurs, they increase. Very good, some of you are answering. That is called de Carvalho's sign. That is called de Carvalho's sign. So de Carvalho's sign is that where the murmur, right sided murmurs, they increase on inspiration, is what is called the de Carvalho's sign. Okay, right. Yeah. Now you just see the this one, mid systolic click with late systolic murmur. Yeah, where do you have this mid systolic click with late systolic murmur? Yes, so mid systolic click with late systolic murmur, it is observed in mitral valve prolapse syndrome, right? And you also observe this in case of tricuspid valve prolapse syndrome. Right? And what is the description of this murmur in mitral valve prolapse syndrome is, it is crescendo decrescendo murmur, same like AS, crescendo decrescendo murmur. Okay, now one quick question just I wanted to ask you all is, in mitral valve prolapse syndrome you will listen the murmur to the apex. Now tell me, does the murmur radiates to the axilla or does the murmur radiate to the base of the heart? Does the murmur radiates to the axilla or does the murmur radiates to the base of the heart? Very good. That is depending upon the leaflet. Excellent. So if the anterior mitral leaflet, if the anterior mitral leaflet prolapses, the murmur will be radiating to the axilla. If the posterior mitral leaflet prolapses, the murmur will be radiating to the base of the heart. Okay, good. Next, yeah. Tell me, what is this murmur? Yes, what is this murmur? This one. Yeah, so this is your ejection systolic murmur, which is also called mid systolic murmur, right? Ejection or mid systolic murmur that you will observe in case of the AS, PS, and as well as HOCM, right? As well as the HOCM. Okay, so this we describe it as crescendo, where there is increase in the intensity of the murmur, then followed by the decrescendo, where there will be decrease in the intensity of the murmur. So crescendo decrescendo pattern, and you take this AS murmur. Where will this AS murmur will radiate to? Where will this AS murmur will radiate to? The AS murmur will radiate to carotids. Very good. The AS murmur will be radiating to the carotids. Okay, so that is what is your mid or the ejection systolic murmur. Done. Now, so that was about the story related to the cardiac murmurs. And next thing is you need to be aware of diastolic murmurs. So what are the conditions where you will have early diastolic murmurs? Conditions where you will have early diastolic murmurs. Anyone? Early diastolic murmurs. So early diastolic murmurs, AR and PR, very good. With the conditions where you will have mid diastolic murmurs, mid diastolic murmurs are present in MS and as well as the TS. MS and TS. Okay. And lastly, in the murmurs that you need to be aware of is the named murmurs, right? You need to be aware of the named murmurs. Okay. So tell me, where is that you have the presence of the Carey-Coombs murmur? Where is that you have Carey-Coombs? Very good. That is acute rheumatic fever causing MR. There you will have Carey-Coombs murmur. Okay. Yes. Next is Graham-Steele's murmur. Tell me, where is that you will have Graham-Steele's murmur? Yes, Graham-Steele's murmur. Very good. So the Graham-Steele's murmur is observed in pulmonary hypertension causing pulmonary regurgitation. Okay. Next, that is the Graham-Steele's murmur. Okay. Then followed by that Austin Flint. Yeah, please tell me, where is that you have Austin Flint murmur? Conditions where you have Austin Flint. Excellent. That is the severe AR causing the mid diastolic murmur. Usually in AR it is early diastolic murmur, but this is a functional murmur. Okay. Right. Tell me, where is that you have the presence of Millwheel murmur? Yes, Millwheel murmur. Anyone? Conditions where you have Millwheel murmur. Excellent. That is in air embolism, right? Air embolism. Okay. Then followed by that you have what is called Dock's murmur. That is DOCKS murmur. Yeah. Tell me the conditions where you have Dock's murmur. Very good. That is mid left anterior descending artery stenosis. You will have the Dock's murmur, right? Then followed by that you have the what is the murmur that you have in AV block? Murmur that you have in AV block. Very good, Shruti. That is Retant's murmur. Right, Retant's murmur. Tell me, what are the conditions where you have the Still's murmur? These are all named murmurs I am trying to discuss. Conditions where you have Still's murmur. Yes, Still's murmur. No one is answering. Very good, Ramya. That is in the child. In children you have this Still's murmur and it's a physiological murmur, right? And it is a physiological murmur. Okay. Next, tell me, where is that you have Cole-Cecil murmur? Yes, Cole-Cecil murmur. Anyone? Very good, Pranita. The murmur of AR that will be radiating to the axilla is what is called as the Cole-Cecil murmur. Then where is that you have the means Lerman scratch. Where is that you have means Lerman scratch? Anyone? Means Lerman scratch. I'm sorry. So you have this in thyrotoxicosis, right? Lastly, another named murmur is cruel hair Baumgarten murmur. Cruel hair Baumgarten murmur. Yeah. Anyone? Where is that you have this cruel hair Baumgarten murmur? Excellent. That is portal hypertension. So all these are your named murmurs, right? All these are your named murmurs. Okay, right. So these are all your named murmurs. Done. We'll go back to our images. Right. Now, areas of auscultation is another important thing. So, what is the best site for auscultation of the second heart sound? Best site for auscultation of second heart sound. Yeah, A, B, C, D, E. Best site for auscultation of the second heart sound. Now, you tell me the options. A, B, C, D, E is your points I have given. Yeah, so that is your point C. This is what is nothing but your Erb's point. This is what is your Erb's point. Okay, and the other areas you are very much aware of. Your A stands for what? That is aortic area. B is what? That is the pulmonary area. C is your Erb's point. And what exactly is your D? D is your tricuspid area. Right? D is the tricuspid area. And what is point E? What is point E? No, point E. That is what is your apex. So apex is nothing but equivalent to mitral area. Equivalent to mitral area. Okay. That is the apex, right? And lastly, yeah, I'll give you one area here. This is F. Can anyone tell me what is this area F? What is this area F? Yes, very good. So this will be your Gibson's area. That will be the site for auscultation of the Gibson's murmur. That is nothing but your PDA murmur. Okay, right. Semilunar valve closure is, I hope everyone has written done. Right, then we'll move on to the next. Yes, semilunar valve closure is represented by. Semilunar valve closure is represented by. So what are these points? This is your A, and this is your B, and this is your C, and this is your D. Already I have discussed this. Anyone? So this will be corresponding to B, that is incisura. B is your incisura. So incisura is the point where the semilunar valve is being closed, right? Now what is this A and C difference? What is this A and C difference? You have A, that is systolic pressure. You have C, that is diastolic pressures. So difference in A and C will be very good. So difference in A and C, this will be the pulse pressure, right? So this will be the pulse pressure. Okay, right. So this is about the graph where it is showing you systolic pressures, diastolic pressures, pulse pressure, and as well as the incisura, right? Yeah. Now this is the image that I wanted to just tell you that in between, during inspiration and as well as during inspiration, there is a split in second heart sound. So in second heart sound, you have a physiological split, and that physiological split that will be there, right? The physiological split that will be there only during inspiration. Now tell me, what is the duration between A2 and P2 during inspiration? What is the duration between A2 and as well as P2 during inspiration? Anyone? During inspiration, how much will be the distance, I mean the duration between A2 and as well as P2? This one. Right? Yes. So that will be around 40 to 50 milliseconds, and that is the reason why you will be able to listen this split, right? Now now quick discussion is, what are the conditions where you have wide pathological split, wide pathological variable split? Anyone? ASD, very good. So it can be due to early A2 or it can be due to delayed P2. So early A2, where is that you will have MR and as well as VSD. Delayed P2, where is that you will have right bundle branch block, you will have delayed P2. Then next is left ventricular paced beats, left ventricular ectopic beats, and delayed P2 is also observed in the pulmonary hypertension. You will also have this in pulmonary stenosis, and you will also have in pulmonary embolism. There will be the delayed P2. So in all these conditions you will have a wide split S2, right? In all these conditions you will have wide split S2. So wide split S2 is due to what? That is due to early A2 and as well as delayed P2. Right? Now tell me the conditions where you have wide fixed split. Conditions where you have wide fixed split. Right, wide fixed split is observed in ASD. Any other conditions apart from ASD? Any other conditions apart from ASD? Even in luteum Bacchus again you have ASD, right? What are the other conditions where you will have wide fixed split? Not in acute MR. Yeah, very good, Vignesh. So that is observed in severe pulmonary stenosis, right, and acute right heart failure or acute right ventricular failure. So these are the conditions where you will have wide fixed split, right? Very good, Vignesh. Yes. Now so that is about the second heart sound where you have the physiological split during inspiration, and you need to know the conditions where you have the wide split S2. I'll ask one quick question on second heart sound, very important. Tell me, what are the conditions where you will have reversible split? Reversible split. Okay, that means you will have P2 first followed by that A2. Reversible split. Excellent. So in severe AS. So in severe AS you will have reversible split. That means you will have P2 first and followed by that A2 will be there. Okay, done. Now can anyone tell me what is the pattern of this breathing? What is the pattern of this breathing? Right, so this is observed, this is Cheyne-Stokes respiration. Which cardiac conditions you will have this? Which cardiac condition you will have this Cheyne-Stokes respiration? Good. So that is observed in congestive heart failure. And what is the differential diagnosis for Cheyne-Stokes respiration? Stroke, traumatic brain injury, healthy people living at high altitude, then toxic metabolic encephalopathy, that is carbon monoxide poisoning. So these are all differential diagnoses for the Cheyne-Stokes respiration. These are all differential diagnoses for the Cheyne-Stokes respiration. Carbon monoxide poisoning. Carbon monoxide poisoning. Okay. Right. And what will be the character of that? There will be increase in the respiratory rate for a while, and followed by that there will be apnea. Again there will be increase in the respiratory rate, and followed by that there will be apnea again. Followed by that there will be apnea again. So this is what is a characteristic feature of the Cheyne-Stokes respiration. Right. Then okay, which chest X-ray is suggestive of increased pulmonary venous pressure? Which chest X-ray is suggestive of increased pulmonary venous pressure? Yes. No, D is your interstitial edema. Actually, all these are the chest X-ray findings because of increased pulmonary venous pressure only, but only pulmonary venous pressure is elevated in the X-ray C. Right, you can see this upper lobe vein distension. You can see that veins are like moving up, and that too they are dilated veins. So this is due to upper lobe vein distension, and this upper lobe vein distension, right, this upper lobe vein distension, it is present in case of the left heart failure. Present in case of left heart failure. And what is your chest X-ray A? Chest X-ray A, it is suggestive of the pleural effusion. Right, chest X-ray A, it is suggestive of the pleural effusion. Okay, and chest X-ray B, it is suggestive of, like, you have the alveolar edema, and this alveolar edema in patients with congestive heart failure, that it is the one which will give you right, it is the one which will give you a bat wing appearance. Right, a bat wing appearance. Okay, and this will be your Kerley B lines. So this part will be Kerley B lines, and this Kerley B lines tells you that there is interstitial edema. Right, interstitial edema. Right, interstitial edema. Okay, so this will be your all the X-ray findings, and all these are found where? All these are observed in patients with a congestive heart failure. Right, all these are observed in patients with a congestive heart failure. Okay, and in congestive heart failure, what is the best method of diagnosis congestive heart failure is? One is your 2D echo. So 2D echo will tell you that whether the ejection fraction is normal or whether the ejection fraction is reduced. But what is the most sensitive biomarker for congestive heart failure? What is the most sensitive biomarker for yes, so that will be your NT-proBNP. Right, that will be NT-proBNP. Okay, right, and we have new cardiac biomarker which will tell you about the prognosis. The one which will tell you about the prognosis, which is a new cardiac biomarker, is soluble ST2. Right, soluble ST2. Okay, but whereas among these three options, that is troponin I, troponin T, and as well as the CKMB, which is the best cardiac biomarker for MI, coronary artery disease? For coronary artery disease, which is the best cardiac biomarker? Very good. So that will be your troponin I. So troponin I is the best cardiac biomarker for the MI, whereas CKMB is the best cardiac biomarker for congestive cardiac failure. Right? Yeah. Tell me, what is this instrument, or what is this intervention, and what are the indications of this intervention? Anyone? What is this intervention? Yeah, it is CRT, which mean cardiac resynchronization therapy. Now, how to identify it is a cardiac resynchronization therapy? So in cardiac resynchronization therapy, we place 3 leads totally. And where are these 3 leads? One lead is in the right atrium, and another lead is in the right ventricular apex, and the third lead is in the lateral wall of the left ventricle. Right, lateral wall of the left ventricle. So this is lead 1, and this is lead 2, and this is lead 3. Right, so this will be present in the lateral wall of the left ventricle. Right, and what exactly does this CRT do? This CRT will improve the synchronization between the two ventricles. Right, will improve the synchrony between the two ventricles. Okay, that is what the CRT does. Right, and the definite indication for the CRT is patients with dilated cardiomyopathy not responding to medical management. Along with DCMP, the ECG should show that there is wide QRS complex, and this QRS complex should be like LBBB pattern with QRS complex more than 150 milliseconds. right? LBBP pattern with QRS complex, right? LBBP pattern with QRS complex more than 150 milliseconds. So that is what is the indication for the placement of the cardiac resynchronization therapy, right? Now what this will do, this cardiac resynchronization therapy, this cardiac resynchronization therapy will improve the ejection fraction of the patient. That is what is the CRT does, right? That is about the CRT. Right. Now tell me, what is the indication for this ECP? Indication for ECP. Anyone? Indication for ECP, that is external enhanced external counter pulsation technique, not in shock. Not in the case of shock. In case of shock, what we use is IABP, intra-aortic balloon pump. Yeah, very good, Vignesh. So that is in refractory cases of right, in refractory cases of the congestive heart failure, we place this ECP. How is this ECP designed? The ECP is designed in such a way that balloons or inflatable balloons which are connected to the extremities, right, the inflatable balloons which are connected to the extremities, they are inflated, right, they are inflated during the diastole. Thereby what will happen to venous return? There will be increase in the venous return, and once the venous return is increased during the diastole, what will happen to your myocardial perfusion? Myocardial perfusion is increased, and this will improve the cardiac contractility. This will improve the cardiac contractility. Okay, so this is about your ECP. This is about your ECP, enhanced external counter pulsation technique. Done. That means a patient is not responding to medical management, then we place this ECP in congestive heart failure. The same thing again, ECP, right? Next, yes. Now this is a 2D echo of one cardiac abnormality. Can anyone identify what is this? 2D echo of one of the cardiac abnormality. And where do you have this? LV enlarged. Is it only LV enlarged? Is it only LV enlarged? So right, so this is the, no, hockey stick appearance is not there here, right? This is the 2D echo of dilated cardiomyopathy. This is a 2D echo of dilated cardiomyopathy. So all the chambers here, RV is not significantly dilated, but usually whatever the picture that you are seeing, that is your LV, LA dilated, RA dilated, so that is feature suggestive of DCMP. Usually all chambers, they're dilated, right? Or maybe this view, that is apical 4-chamber view, is not showing you that RV is dilated, but RV also will be dilated in patients with the DCMP. And in DCMP, yeah, what type of ejection fraction is that you see in DCMP? Is it HFpEF or HFrEF? Very good. So it is HFrEF. Okay, heart failure with reduced ejection fraction, where the ejection fraction will be less than 40%. Ejection fraction will be less than 40%. Okay. Now another important thing is these patients will also have functional MR and functional TR, right? Functional MR and functional TR. That is another thing that you will see in case of patients with the dilated cardiomyopathy whenever you do a 2D echo, right? So this will be the 2D echo findings in patients with the DCMP. Done. Next, and these patients with DCMP, because the ejection fraction is reduced or the systole is reduced, because the systole is reduced, they can have stasis of the blood, right? They can have stasis of the blood, and there is a chance of the clot formation, right? There is a chance of the clot formation, and that clot, if it is there, that can be made out on the 2D echo, right? Yeah. Yes, diagnosis of this chest x-ray. Diagnosis of this chest x-ray. Money bag appearance is there, huh? So usually in case of water bottle appearance or money bag appearance, both the sides, the megaly should be there. Yeah, so this is the ECG of the cardiomegaly, and it can be the chest x-ray of the dilated cardiomyopathy, or it can be observed in patients with a ventricular septal defect, because even in ventricular septal defect you have this cardiomegaly. So how much should be the cardiothoracic ratio? How much should be the cardiothoracic ratio to call it as cardiomegaly? Anyone? Right, so that should be more than 0.5, right? And how much should be the cardiothoracic ratio in children to call it as cardiomegaly? What should be the cardiothoracic ratio in children to call it as cardiomegaly? In children it is not the same 0.5. Anyone? In children? No, it's not more than 0.7, it is more than 0.4. In children it is more than 0.4. Okay, right. That is about the cardiomegaly. Next, now what exactly is this instrument, and what is the use of this instrument? Yes. What is the use of this instrument? Yes, very good, Myra. That is CRT, cardiac resynchronization therapy. I have shown you one animated image above, but this is a real image. So this is your PG, that is pulse generator, okay, which will generate the impulse. And how to identify that CRT? There should be 3 leads. I'll show you. So this is one lead which is there in the right atria, and this is another lead which is present in the right ventricle, and this is another lead which is present in the lateral wall of the left ventricle. Another lead which is present in the lateral wall of the left ventricle. Okay, so this is about your CRT. Now, so in case of indication already I have discussed, that is in patients with the DCMP, that is dilated cardiomyopathy. Okay, now tell me, what is the most common toxin that will be causing dilated cardiomyopathy? What is the most common toxin that will be causing dilated cardiomyopathy? It is not ICD. It is not ICD. How to rule out ICD, I'll tell you. Yeah, so the most common toxin will be alcohol. Now in case of the ICD, you will have only 2 leads, and where will be that lead? Right atria and as well as right ventricle. And in ICD you don't have 3 leads like which is present in the lateral wall of the left ventricle here, right? So the most common toxin will be the alcohol. Tell me, what are the drugs that will be causing dilated cardiomyopathy? What are the drugs that will be causing dilated cardiomyopathy? Right, very good. So the drugs causing dilated cardiomyopathy will be adriamycin. Okay, then we have trastuzumab, right? Trastuzumab. Then the other one is, yeah, so that is cocaine. Then doxorubicin or daunorubicin. Okay, so these are the drugs that will be causing dilated cardiomyopathy, right? Next, tell me, what are the endocrine disorders where you will have dilated cardiomyopathy? What are the endocrine disorders that will be causing dilated cardiomyopathy? Endocrine disorders. Yeah, so you will have in both the thyroid related disorders, that is in hypothyroidism and as well as the hyperthyroidism. Hypo and as well as the hyperthyroidism. And the other condition is in patients with diabetes mellitus, you will have the dilated cardiomyopathy, right? Hypo and hyperthyroidism and as well as diabetes mellitus. Okay, right. And next is nutritional deficiencies are asked very commonly. So tell me, what are the nutritional deficiencies where you will have this dilated cardiomyopathy? What are the nutritional deficiencies where you will have dilated cardiomyopathy? Very good. So that is observed in B1 deficiency and as well as selenium deficiency. Now if selenium deficiency is associated with Coxsackie virus, that is called Keshan disease. That is called Keshan disease. Right? And in patients with dilated cardiomyopathy, you will have the feature similar to that of the heart failure, and along with first and second heart sound, you will also listen third heart sound. Okay. Yes. Diagnosis. What is the diagnosis of this? Very good. So this is what is nothing but your Takotsubo cardiomyopathy. The another name for Takotsubo cardiomyopathy is, it is also called apical ballooning syndrome. Right? Also called apical ballooning syndrome. Or the another name for this is, it is also called stress cardiomyopathy. Yeah, it is also called broken heart syndrome. What is the name of the criteria? What is the name of the criteria? What is the name of the criteria for these patients? Yeah, so it is modified Mayo's criteria. So according to modified Mayo's criteria, there should be ST segment elevation, right, in the ECG, and 2D echo will be showing hypokinesia. 2D echo will be showing hypokinesia. What is the next thing? What will happen to troponin? What will happen to troponin? Troponin should be troponin should be elevated. And third important thing in the modified Mayo's criteria is coronary angiogram should be normal. So this is how you will be able to rule out the Takotsubo cardiomyopathy from the normal, the Takotsubo cardiomyopathy from the MI. MI, because in MI you will have atherosclerotic plaque. And lastly, you should rule out pheochromocytoma, because these patients also will have excessive catecholamines which are responsible, and even in pheochromocytoma also you have excessive catecholamines. Okay, right? And 4 out of 4 should be there to call it as the Takotsubo cardiomyopathy, right? Yeah. Now in hypertrophic cardiomyopathy, what should be the minimum increase in the thickness of the septum? Right, very good. So not 3 centimeters, not 3 millimeters. 3 millimeters is very, very small. So it should be more than 1.5 centimeters. The increase in the thickness of the septum should be 1.5 centimeters. And because the septum will cause the outflow tract obstruction, that is why it is called HOCM. That is why it is called HOCM. And in patients with HOCM, what is the most common gene that is affected? What is the most common gene that is affected in patients with the development of HOCM? Yeah, that is beta myosin gene, which is present on which chromosome? Right, it is actually beta myosin protein, which is coded by, yes, which is coded by this MYH7, right? And on which chromosome? Yeah, present on chromosome 14. And what are the other proteins which are being defective? What are the other proteins that are being defective? Right, so that is myosin binding protein C, right, myosin binding protein C, and the other one is troponin I. The other one is troponin I. Okay, so these are the genes which are being defective for the development of the hypertrophic cardiomyopathy, right? And the next important thing for the development for this hypertrophic obstructive cardiomyopathy that you need to know is, when you do a biopsy, right, when you do a biopsy in patients with HOCM, what does the biopsy shows? Very good, Vignesh. So this will be what is called helter-skelter appearance. Right, helter-skelter appearance, right, not ninja star. Okay, now when you do a cardiac catheterization in patients with HOCM, right, when you do a cardiac catheterization in patients with HOCM, what is that characteristic sign that you will notice? What is that characteristic sign that you will observe in patients with HOCM. No, no, no. The SAM you can observe even in 2D echo also. 2D echo also you will observe this SAM. I'm asking in cardiac catheterization. What is that important sign? SAM you can observe even in 2D echo as well. You did not do cardiac catheterization to making out the SAM. Yes. Banana shaped ventricle. Banana shaped ventricle you can have this in 2D echo also, right? So even this 2D echo also will show you that banana shaped left ventricle. For that you need not do ace of spades, confirms the triangle, no. Right, if you people have attended, yes, only one student answered that, that is Hariharan, very good Hariharan. So the very important sign is broken bro, Braunwald sign. Right, broken bro, Braunwald sign. Okay, Hariharan, can you tell me what is broken bro, Braunwald sign? What is broken bro, Braunwald sign in the cardiac catheterization? Okay, so what is that you want? You people want just only to name remember, or you want me to explain what is broken bro, Braunwald sign? Yes, decreased VPC pulse volume. Okay, right, I'll tell you what exactly is this. I'll explain. Okay, first thing I just wanted to ask you one quick point. Whenever there is a VPC, right, whenever there is a ventricular premature contracture, whenever there is a ventricular premature contracture, immediately after the ventricular premature contracture, right, okay, next to the ventricular premature contracture, how will be the stroke volume? How will be the stroke volume immediately after the ventricular premature contracture? Anyone? Okay. Yeah, very good, Akilan. So after ventricular premature contracture, the stroke volume is increased. Okay, I'll take you a new page. This is like little explanation is required. Okay, so after a VPC, ventricular premature contracture, the stroke volume is increased. And you can ask me, sir, why stroke volume is increased after a ventricular premature contracture? You see, your ventricular premature contracture, tell me, is it a weak contraction or is it a strong contraction? Is it a weak contraction or is it a strong contraction? Very good, Pranita. So this is a weak contraction. Now when it is a weak contraction, how will be the stroke volume during VPC? How will be the stroke volume during VPC? During VPC, how will be the stroke volume? Very good, Pranita. So stroke volume is reduced. Good. Now when stroke volume is reduced, what will happen to LV end systolic volume? What will happen to LV end systolic volume? LV end systolic volume is increased, right? LV end systolic volume is increased because the ventricle is having a poor contraction. So the amount of blood which is going out into the aorta is not 70 ml, it is less than 70 ml, and blood is remained within the ventricle. So LV end systolic volume increases. Great. Now to this LV end systolic volume, what will add up now? Your diastolic blood will add from the left atria. So tell me, what will happen to your LV end diastolic volume? What will happen to the LV end diastolic volume? LV end diastolic volume is increased, right? Now when LV end diastolic volume is increased, what is happening to the initial length of the muscle fiber? What is happening to the initial length of the muscle fiber? Initial length of the muscle fiber is increased. when initial length of the muscle fiber is increased, according to your Frank-Starling's law, what will happen to the force of contraction? What will happen to the force of contraction? Force of contraction will be increased. As the force of contraction is increased, what will happen to stroke volume? What will happen to the stroke volume? The stroke volume is increased. Stroke volume is increased. So immediately after a VPC, stroke volume is increased. That is the phenomena after VPC. Now let me take up the HOCM. Now let me take up the HOCM. So in patients with HOCM, what happens is, in patients with HOCM, if at all if the HOCM patients has a VPC, after VPC, okay, now okay, another point, just before going to the HOCM, one more point I want to discuss. Now when stroke volume is increased, what will happen to systolic blood pressure? When stroke volume is increased, what will happen to systolic blood pressure? Okay, systolic blood pressure is increased. Now when systolic blood pressure is increased, tell me what will happen to pulse pressure? Tell me what will happen to pulse pressure? Right, that is increased. So there will be wide pulse pressure. That is what will happen in a patient with VPC who is not having a HOCM. Now let me take up the same VPC in patients with the HOCM. Right, same VPC after the HOCM. I mean, sorry, in HOCM after VPC, how it will happen. Now, what did I discuss here? After VPC, there should be wide pulse pressure, or there should be increased systolic blood pressure, is what I have discussed after a VPC, right? But what is Broken-Brown phenomena? What is Broken-Brown? Cells over, I think. Yes, am I audible now? All right. Okay. So now, first of all, you please tell me, is this part understood by everyone or not? This VPC increasing the systolic blood pressure and wide pulse pressure, all of you, did you understand this concept first of all? Great. Once you have understood this concept, now exactly what you mean by this Broken-Brown, I'll discuss now. Now, so in HOCM patients, after a VPC, there will be decrease in pulse pressure. This is what is called Broken-Brown phenomena, or Broken-Brown sign, and that you will be able to make out on cardiac catheterization. right? This you will be able to make out on the cardiac catheterization. Okay, this is what is called Brockenbrough. Now the question is, sir, why after VPC too you said like there should be increased stroke volume, and there should be like increased systolic blood pressure, and there should be wide pulse pressure is what you have discussed. Why in HOCM after VPC the pulse pressure is being decreased? Why? Because in HOCM after VPC actually there will be increased LV and diastolic volume. I am not denying that LV and diastolic volume is observed even in patients with the HOCM as well, but because of increased pressure or due to increased velocity of blood, right, due to increased velocity of the blood flow across the septum in HOCM there will be exaggerated SAM, right? There will be exaggerated SAM. That means more and more blood try to escape across that hypertrophied septum. The SAM will come into the play. That is systolic anterior motion of the mitral leaflet will close the outflow. Once it closes the outflow, what will happen to the stroke volume? What will happen to the stroke volume when the SAM comes into picture in patients with HOCM? So stroke volume will be decreased. Once stroke volume is decreased, what will happen to the systolic blood pressure? Once stroke volume decreases, what will happen to systolic blood pressure? Systolic blood pressure decreases. As the systolic blood pressure decreases, these patients will have a narrow pulse pressure. These patients will have narrow pulse pressure, and this is what is called as the Brockenbrough-Braunwald sign that you will be able to make out on cardiac catheterization. Okay, so now don't break your head about this point, that is SAM. Now sir, why SAM is increasing? SAM I have already said. Okay, SAM stands for systolic anterior motion of mitral valve leaflet. If you want me to show that image, I'll show you that image also. Right, I am trying to show you that image of systolic anterior motion of anterior mitral valve leaflet. Okay. Right, this is what is your SAM. This is what is your SAM. So where the anterior mitral leaflet will move towards the hypertrophied septum. When anterior mitral leaflet moves towards the hypertrophied septum, this is what is called SAM. Preeti, did you understand this? Now the next question that pops up in your brain is, sir, why does this SAM occur? This part, don't go and break your head for this part. Why SAM is occurring? There is one phenomena called Bernoulli's phenomena, that is purely physics, right? So due to this Bernoulli's phenomena, you have this appearance of the SAM. Okay, so that is what is responsible for your decrease in pulse pressure after the VPC in case of HOCM, which is called Brockenbrough-Braunwald sign. Okay, so I hope everyone is clear with this phenomena now, Brockenbrough-Braunwald phenomena. Right, very simple. Usually after a VPC, stroke volume should increase, but here the stroke volume is decreasing and there is a narrow pulse pressure, is what is called Brockenbrough-Braunwald phenomena. Right, next. Now after having said about, yes, now this will be the ECG in patients with the HOCM. Right, so can anyone describe the ECG in patients with HOCM? Can anyone describe the ECG in patients with HOCM? What is that you will observe? So ECG, very good. So you will have deep dagger shaped Q waves. Right, you will have deep dagger shaped Q waves in 1 AVL, V5 and V6, right? And also observed in 2, 3 and AVF. The other ECG changes will be deep T wave inversions, and these deep T wave inversions, that will be asymmetrical T wave inversions, right? So this will be asymmetrical T wave inversions, okay? And this asymmetrical T wave inversions, you can see that these are your asymmetrical T wave inversions, and that also you will observe in 1 AVL, V5, V6, wherever you are having the deep dagger shaped Q waves. And another point is, you will have dominant R wave in V1. Usually you don't have a R wave in V1, there will be dominant R wave in V1, right? Dominant R wave in V1, okay? So this will be the ECG changes in patients with the hypertrophic obstructive cardiomyopathy, right? And next, now this is like hypertrophy at the septum. If the hypertrophy is at the septum, then the shape of your LV lumen will be banana shaped LV. The shape of the LV will be banana shaped LV. Whereas if the hypertrophy is at the apex, this we call it as the apical hypertrophy. Yeah, tell me, in case of apical hypertrophy, what will be the shape of the LV? What is the shape of the LV in apical hypertrophy? Anyone? Right, so this is what is called ace of spades, right? So this is what is called as the ace of spades, okay? Right, and yeah, so this is what is giving you this ace of spades appearance, okay? Right, and tell me, what is the drug of choice in patients with HOCM? What is the drug of choice in patients with HOCM? Anyone? Yeah, so drug of choice in because they'll give you the same image, right? They'll give you the same image and they'll ask you what is a preferable drug in these patients, right? Or the drug of choice. So the drug of choice in these patients will be the beta blockers, and then followed by that you should give, I mean, if the individual is having any contraindication to this beta blockers, then the alternative will be non-dihydropyridine, right? Non-dihydropyridine calcium channel blockers. So that will be the drug of choice, okay? And the next important is, what are the drugs contraindicated in HOCM? What are the drugs contraindicated in HOCM? Drugs which are contraindicated in HOCM, anyone? Very good. So your furosemide is contraindicated, then nitrates are contraindicated, then digoxin is contraindicated, right? And then next important drug which is contraindicated is sympathomimetic amines, right? So now tell me, sympathomimetics, tell me these drugs, are they contraindicated in apical hypertrophy also? These drugs, are they contraindicated in apical hypertrophy also? No. So only these are contraindicated in HOCM, but not in, right, not in HCMP, right? Not in case of the HCMP, okay? Very, very important point, right?